My name is Julie Gonzalez from the DC Hospital Association, and I'll be introducing our first session. We'll start today with a presentation on the trajectory of the opioid crisis across the country and the value of medication-assisted treatment in helping to improve the lives of individuals with opioid use disorder. Our speaker for this session is Dr. Denny Carisse. Dr. Denny Carisse is a clinical psychologist and has been part of the recovery community for over 35 years. She is currently the Chief Science Officer of Recovery Centers of America and Adjunct Assistant Professor at the University of Pennsylvania. She serves on numerous boards and has worked extensively internationally with treatment providers to help develop national systems that integrate scientifically validated tools into clinical treatment delivery. She's also been featured in segments on Nightline, MSNBC, Fox News, ABC, CBS and NBC Evening News, Access Hollywood, New York News, and has also been quoted in popular newsprint media such as US News and World Report, Fox News, Wall Street Journal, and others. She has also published over 100 articles, books, and chapters. I'd like to welcome Dr. Carisse to begin her presentation now.
Thank you so much, and thank you, Julie and Eden and Elizabeth, for all your help as we went through this. Let me see if I can share my screen now. Let's see. All right. Okay. So again, thank you for having me. Happy to be here even virtually this year and talk about opioid use disorders. I want to talk about kind of how we got here, the medications for the treatment, and also how to talk with sites and individuals in sites who may not be really energized about having these medications. And then also at the end, I'm going to do some slides because I have some very recent data about the impact of COVID on the community, on our patients, on our treatment programs, and on the role of telehealth and virtual treatment. So again, thanks for having me here. This presentation is a little longer than it should be, so I kept in some slides that I thought you might want later on to be able to refer to. The PDF is available, the presentation is available to you. So again, we're going to just talk about how the opioid crisis came about and the three waves of the crisis. We're going to talk about the primary medications used in the treatment of substance use disorder treatment and become familiar with the harm reduction benefits. We're gonna have various approaches for discussing the importance of MAT, particularly with providers that are abstinence-based. I think I have a spelling leave with various. So, all right, so you're going to leave with various approaches to discuss. Now I get my own writing, and then understand again how COVID has impacted the field. A couple of quick notes. I generally use substance use disorder instead of addiction, substance abuser, because there's a lot of literature that is, it feeds the stigma, but apologies when it doesn't work. So you get so used to a phrase, and substance use disorder doesn't really roll off your tongue, but that is generally important to me. Those slides I told you about that were kind of extra, but I wanted you to have them. They're called reference slides. I'm going to kind of skip through them, and they're labeled reference slides, but I wanted you to have them. Okay. All right, so let's start with understanding how the opioid crisis came about, including what we call the three waves of the crisis, what NIH and the CDC call the three waves of the crisis. So starting back at 2010, there were about 38,000 overdose deaths. 21,000 of them were opioid overdose deaths. When you hear the numbers on overdose deaths, it's important to really read exactly what it says, because overdose deaths in general also include overdose deaths because of medication errors in the hospital or at home, but a good chunk of those are opioid overdose, and that was 2010. By 2014, we're up to 47,000 and 28,000 that are opioid overdose deaths. 2014 was also the time when we started realizing how many people were trying heroin for the first time. So in 2014, 212,000 people tried heroin the first time. That's about 600 people every day in this country tried heroin for the first time. That's really a striking number to me. Drug overdose deaths became the leading cause of accidental deaths in the US with the 47,000 drug overdose deaths. So by 2015, we're up to 33,000 opioid overdose deaths. 2015 was also a time when we realized that unintentional drug overdose deaths quadrupled since 1999. And by 2016, the number of overdose deaths, including prescription opioids, was about 5 times higher than 1999. So by 2017, we're up to almost 50,000 opioid overdose deaths. 2017 also was the time when we started looking at what was, I mean, we had been looking, but we started quantifying what was going on. About 80% of opioid addicts begin with prescription medications for pain, 60% with our own prescription, 20% with the prescriptions of family members or friends. So the scope of the problem, of the overdose problem, this is year over year. You see starting in 2010, and we look at by 2014, it's increased, and each year over year. If you go down to 2017, what you see is that the number of overdose deaths in general increased 14%, but the number of opioid overdose deaths increased 68%. I'm sorry, 16%. In the presentation, all of these are linked to the data and where I got the data. So I'm not given any, if I ever give an opinion, I'll tell you, but I'm a scientist, so it's always about the data for me. So why such an increase? Well, there's a lot of work that's been done on this, and the nutshell version is this, that it was fueled by a drastic increase in the number of prescriptions written, poor education about the use of these prescriptions, unethical and aggressive marketing by pharmaceutical companies, an influx of higher purity of heroin at a lower cost from Mexico specifically, newly available more potent analogs like the fentanyls, carfentanil, and all of those came together, and we saw this tremendous increase in the number of people living with and dying from opioids. So the long story of that, and this is the reference slide, is I have some data here on exactly what happened to let that all happen, but the reality is that's all in this book. This is really a wonderful description of exactly how this came about, and it was just this trifecta of this confluence of things that all happened that allowed this to happen in our country. So, all right, opioid overdose decreases and the changes going back to 2017-18, the number of drug overdose deaths decreased. We believe that that's because, and I think it was a JAMA article just came out showing that that was not because what we're doing is working so much, it was because of the fentanyl analogs and the impact of some things, and we'll get to that in a minute. But essentially there was a decrease in the availability of the fentanyl analogs. So it was interesting because from 2017-18, opioid-involved death rates decreased by 2%. Prescription opioid death rates increased by more. Heroin decreased by 4%, but the synthetic opioid-involved death rates increased by 10%. So methadone is a synthetic opioid, but that's not what we're talking here. We're talking fentanyl, carfentanil, and all their analogs, and that just really increased then. So they increased 10%, 31,000 people overdosed from synthetic opioids in 2018. So here's this number in deaths involving synthetic opioids, in the country, and just this, in research, when you see this climb like that, it's really striking. All right, so we get to 2019 and we look at this. 1.6 million people in the US have an opioid use disorder based on the NISDA, National Household Survey on Drug Use and Health. I actually believe they took the word household out now. That was down from 2 million in 2018. That's a good thing, right? Then after recent decreases, opioid overdose deaths increased again in 2019 by about 5%. It was still lower. It's a lower number of increase, than years prior, but it's still an increase. So prescriptions, heroin, and fentanyl, you know? So we had this prescription problem, people transitioned to heroin, then there was fentanyl. Like, you gotta think to yourself, well, what next, you know? Well, what came next are the opioid analogs, and this was just such an interesting time. So the DEA calls these analogs the most potent commercial opioids in the world. So what are fentanyl, carfentanil, and 4,45-5201, right? I put that there because it's so interesting. There were so many of these analogs that many of them just have numbers, not names. So fentanyl, as you may know, if you're a physician or a nurse, it's generally used during anesthesiology or for people with severe pain, typically just after surgery. That's the most common use. Carfentanil is an analog of fentanyl, and the only accepted use for carfentanil is in veterinary medicine. There's no human use of carfentanil that's approved. They say it can be 10,000 times stronger than morphine. And then chemical 4,4,40,5201 is an analog of carfentanil. Well, what's an analog? Well, it's kind of important to know because there's over 1,400 of them now. So if you look on the left here, this is the chemical structure of carfentanil. And on the right, we're talking about chemical 4,40,50,01. And you see that's the chemical, you know, drawing of the molecular structure of this new chemical. And what you see here is that there's just this little, see right there, there's nothing, and right there, there's something. Well, that's what makes it not carfentanil. So what happened initially was that these new chemicals were coming out, and it really, to me, it begs the question. I mean, you know, people that are making and dealing drugs, they're not buying, you know, there's many of them in the business that could have a perfectly good living as a chemist, a real chemist, or a scientist. You know, I mean, these are not stupid, you know, these are not people that are just, you know, slinging drugs on the, I mean, it's just amazing to me that there's 1,400 of these, and the brain power that could have been used for something a little better than this, you know? So the interesting thing was initially, let me just go back. So this new chemical will come out, and again, over 1,000 of them, 1,400 of them. And it wasn't illegal. And it wasn't illegal because it didn't exist. So it can't be illegal because it didn't exist. It has to go through this very long process of being judged to be an illegal substance. And so there was a time in 2018, 2017, where these were flooding in, much of it from China, much of it by mail, US Postal Service, frankly. And if they found it, it technically wasn't an illegal substance. So we had, I think, a huge win in February 2018. So the analogs were getting emergency scheduling by the DEA. So this new analog would appear, the DEA, as soon as they found out about it and could get their hands on it, went into an emergency system of scheduling it. But the really big win, and again, these were illicitly manufactured, driven by a quest to evade the associated problems with use, possession, and distribution of an illegal substance, right? After 2018, these were all automatically Schedule 1 based on the similarity between the chemical makeup and whatnot of fentanyl relevant to any analog not already scheduled. So we went from having to notice it, find it, get our hands on it, test it, and get it through the FDA of saying, okay, this is an illegal substance, one of these 1,400, to being able to say, we found this substance that nobody's seen before. By the way, it's Schedule 1 because it's based on the similarity of the chemical makeup. And that really was a big win. This is why some folks feel that in around 2018 into 2019, early 2019, the number of overdose deaths decreased because we were able to do this. So, you know, it's, I think that there's a lot of other things we've done as a country that have also helped that, but this is now looked at as the primary reason for that decrease. So you see here I added 2018, 2019, which I could finally get my hands on that data, and we've got a decrease in overdose deaths in 2018, and then a slight increase from that in 2019, but not back up to 2017. I'm incredibly interested in the 2020 numbers because, as you'll see at the end of the presentation, the amount of evidence we have that people that are in recovery are relapsing, that people who didn't have problems already do, that the stress that, and the assumption is the stress of COVID, the secrecy of COVID, the ability to be at home and think nobody will know, has really led to people struggling and using more alcohol and more drugs to get by. All right, so the three waves of this crisis were let's go wave one. From 1999 to 2010, the first wave of the overdose crisis was all about prescription opioids. Wave two, 2010 to 2016, was all about the increase of heroin availability, purity, the low price, and also the start to the cut back of the ability to prescribe opioids in an inappropriate manner and in a and there are a lot of things here. I don't know if it's in a later slide, but for example, one of the great things was the prescription drug monitoring program. So we went to where we would have people who would get 4 different 30-day opioid prescriptions from 4 different doctors and get all 4 of them filled in the same week, and each one was a month's supply. Well, the prescription drug monitoring program decreased that, and then a while after, fairly quickly, but you know, you wish it was faster, we got interoperability of that between states. So we're on that in Philadelphia. I am, 20 minutes from New Jersey, 20 minutes from Delaware. I am, 45 minutes from Maryland. So somebody could go to those different states and get 30-day prescriptions all in 1 week. Now we have the interoperability between states. Not perfect, but it's much better than it was. Wave 3, of course, after that, and we're kind of in this now, are the synthetic opioids, not methadone again, but particularly illicitly manufactured fentanyl, IMF, illicitly manufactured fentanyl. And more recently, we've got fentanyl mixed with stimulants. And it's an interesting thing about why that could be. There's been all kinds of guesses. So this is not really based on the science, but what I've heard from patients and what I have read, again, not from empirical studies, but from observations, is that there's a lot of different things going on there. A lot of people that have an opioid use disorder, maybe live on the streets, they want to stay awake because they don't want to get robbed or attacked, so the stimulants allow that. They can't afford food, so that way they're not hungry. But we've also had incidences in Philadelphia. We had a weekend where 17 people overdosed and 11 of them died, and they thought they had purchased cocaine and it was laced with fentanyl. So it's also being mixed in without people's knowledge, and that's really terrifying. So here it is in a kind of a pictorial. So you have the purple line, if it's coming up the right color, is the prescription drugs. The orange is the heroin, and then you see that shoot up in wave 3 of the synthetic opioids. I worry about 2020 and a wave 4. What's going to happen with overdose deaths or opioid overdose, suicide, homicide. All things are going up. And again, I have some data on that later. But it is a real concern. I really do think we're going to have a 4th wave, and it's going to be around the 2020 increase in these medical, social, drug use exacerbations. So again, what's helped? Some aspects are getting better. The prescription drug monitoring program, medical students, physicians are getting more education about pain treatment and substance use disorder. Very little, but some. There's increased use for naloxone to treat the overdose. And in some areas, I have to say, in some areas, the police have been a huge part of the solution. I mean, I don't know a group that has redefined their job as much as police in regard to addressing the opioid problem. They, in many places, they're working almost as social workers. They're finding people treatment. They go to the scene, somebody gets revived. They call them 3 days later to see how they're doing, if they want treatment, if they refuse it that day. I mean, those are really remarkable, actions that across the country, all different police forces have done different things, but they've been a help. But all right, so it's getting better. Well, why isn't it going away? So it's not going away because, you know, heroin is much more less expensive. 80 milligrams of OxyContin costs about $80 on the street. It's about $1 a milligram. $20 of heroin is about equal to that, leading more people to transition. Luckily, there's not as much prescribing, so that's great. The heroin we get from Mexico is pure and less expensive than it was 10, 20 years ago. And really importantly, synthetic opioids, the fentanyl, their analogs, are much more deadly. They can be, you know, made and or ordered online. And the online ordering has decreased a bit, but it still is happening on the dark web. All right. Let's look at the next two objectives, which were to be able to identify the medications and become familiar with the harm reduction benefits. And I'll go through this pretty quickly because I know that folks know a bit about this, but just to look at the medications overview, the three primary medications, methadone, buprenorphine, naltrexone. It's interesting. I always have to sit back because I'm not a physician or a nurse and remind myself, you know, what's an agonist, a partial agonist, an antagonist. So, you know, methadone is a full agonist. It binds to the receptors and activates the receptors fully. Partial agonist, buprenorphine, binds to the receptors, doesn't activate them as much. Naltrexone actually binds to the receptors but doesn't activate them and blocks other opioids from binding to the receptor. So I always kind of, you know, refresh my mind that, you know, the agonist, methadone, buprenorphine is a partial agonist. These are medications that are easy to start. They're a little bit more tough to stop. When people stop these abruptly, there's often a very frequent relapse, and there is there's potential for abuse and diversion. The antagonists like the naltrexone, the monthly shot of naltrexone, it's more complicated to start that medication. You have to detox first. It's very easy to stop. There's really no physiological, there's not this physiological withdrawal. And there's not an abuse potential with them in general, but it also prevents opioid for pain relief. So two of the most common things, well, one of the most common things we hear with people that don't want to go on an antagonist is that I don't want to go on an antagonist because, like, what if I get in a car accident? I won't be able to feel any of the medication for the pain. And that's clearly an indication of somebody who simply doesn't want to go on it, you know? The other thing we're hearing recently, maybe it'll come up later, is people that want to go on buprenorphine, they want to go on Subutex, which does not have the naltrexone in it, because they say they're allergic to that. So let me get to that slide to describe that a little more eloquently, right? Okay, so again, I'm going to fly through this. You know, you have this information. It actually was produced in the 1930s, not many advancements until the 60s and 2001. You know, it activates the opioid receptors in the brain, but when dosed correctly, it doesn't cause, you know, this incredible high or lead to severe cravings. Gradual onset, you know, it prevents withdrawal, theoretically blocks the high you get from drugs like heroin, hydrocodone, morphine, oxycodone, and all the other opioids. So this is a graph that shows you, this is from a JAMA article by Bob Dole. You know, and this is true today. This is from 1971, this graph, but it's true today. This is kind of a, you know, methadone is kind of this steady state, you know, whereas taking heroin has got these ups and downs, and that's kind of the part of the methadone, you know, the reasoning behind the methadone being something that allows you to adjust to the dosage and to be able to work and live life more fully. So tons of studies on methadone. I mean, just tons of them. Improved treatment retentions. People are 60% less likely to abuse IV drugs, less likely to seroconvert to HIV/AIDS. About 60% maintain abstinence from heroin. And these are all different studies. The treatment statistics as of October, 49 states and DC have opioid treatment programs. We used to call them methadone maintenance programs. I don't know if anybody knows, but the one state that doesn't have it is Wyoming, and about 1,600 treatment programs. and it's projected certainly to grow in the next couple of years. It already has grown from that. And here's just a national map, which is so interesting because you see the east and west coasts. And if you look in the middle of the map there, you see Wyoming without any of the blue dots in it. So it's kind of interesting. They have a law that you are not allowed to have a methadone clinic. So interesting. So let's go to the next one. Buprenorphine, considered the absolute most recent advance in MAT, can only be prescribed by a certified physician, which is interesting to me because you have to go get an 8-hour class. You've got to get this waiver to prescribe the treatment for an opioid use disorder, but you don't need to do anything to prescribe the opioids, right? So, that just kind of gets at me. The first MAT, the first medication available outside of a traditional opioid treatment program. It's a partial agonist. It minimizes cravings and withdrawal. It has opioid blocking effects of methadone, safer, longer action. Okay. The safety of buprenorphine is that it's considered safer, and then the combination that's most common is Suboxone, which is the buprenorphine and naloxone. Sorry, I think I said Naltrexone earlier. I'm sorry. Buprenorphine and naloxone. And what we're having now is some people saying, oh, I don't want Suboxone, I want Subutex because that doesn't have the naloxone in it. I think that's, and I'm allergic to the naloxone. So that's an interesting, that's just something I've heard from some patients and whatnot. But I actually think this is just brilliant, frankly, when they came out with this, because the naloxone, of course, is the opioid antagonist, but it's inert unless the person tries to dissolve the drug and inject it. So it prevents the diversion for IV drug use. Nothing prevents the diversion of taking more than as prescribed, right? So it's not completely safe, but it's definitely much safer. So, and you can see from 2003 on into very recently the adoption of methadone, and this is the number of patients in treatment, and it's in the 100. Each number is multiplied by 100,000. So you see this really nice growth of buprenorphine medication that has increased, which I think is great. And I think it's also great that people can get their medication without having to show up every single day at a clinic or an opioid treatment program, and really gives the ability to function in society, I think, much better, to hold a job and things like that, to go on vacation, which is tough when you're on methadone. So, all right. Naltrexone, again, this is a reference slide, just so you have some dates. Uses is it's an opioid antagonist. It blocks the opioid receptors. Important to note, it blocks the opioid receptors both inside and outside the body. So both the internal and external opioids. It doesn't activate it, and it's used to manage both alcohol and opioid dependence. It could be taken orally, but there's a ton of problems with compliance with that. And the most common is that it's injected monthly. No withdrawal associated with stopping naltrexone. And you look at the difference between people being inducted on naltrexone versus buprenorphine, naloxone. And you can see, and this is from 8 different sites, a larger study, that it is definitely easier for people to start on the buprenorphine. They're much more likely to start on it. And the reason for that is because to start on the extended release naltrexone, you've got to be detoxed first, and that's not comfortable for people. Just a note on naloxone or Narcan, it's not a treatment for substance use disorder. It doesn't treat opioid dependence. It is an incredibly good treatment to treat overdose. So it doesn't treat the disorder, it treats the overdose. Short acting, reverses the effects of the opioids. It knocks them off of the receptor so that the heroin can't have any more action, and it blocks them from reattaching. Doesn't work for sedatives like Valium, Xanax, amphetamines, cocaine, but it is a great treatment for an overdose. Few questions, usually works within 2 minutes. Few questions, I'll go pretty quickly with these, that we always get is, why doesn't everybody respond to the first Narcan dose? And that could just be because so many of the receptors are so tightly bound with the drug, and that's usually typical of the synthetic opioids, the carfentanil and the analogs. Why do people have to go to the emergency department even if they feel fine? So if you've been around this and you've seen this a number of times, and I have, when people overdose and they're virtually dead and they get administered Narcan and it saves their life, They wake up, they are furious, they are angry. You have messed up their high, even though they were going to die, and they're angry, and they don't want to go to the emergency department, and they have to go because it's entirely possible that that the synthetic opioids, you knock them off the receptor, the person wakes up. I mean, they literally wake up like this typically. And then to the third issue on this slide, they can actually overdose after Narcan without taking any more opioids. And that's because the half-life of the Narcan is shorter than the half-life of some of the synthetic opioids. So the Narcan will go in, it'll bust the opioid off the receptor, it'll block the receptor, but its half-life is shorter than the half-life of the opioid, so that you could actually overdose again without taking any more of a drug. So people always have to go to the emergency department. And there's actually a film coming out today. I'm going to the premiere tomorrow, called Snow Babies. Incredible film. Just, I consulted on it, and I consulted on the Narcan scene and on the overdose scenes and whatnot. And it's an incredible film about heroin addiction, all done in Philadelphia, but heroin addiction in kind of, of a high school, or in this nice Catholic school, and how the effects of heroin have touched everywhere. Beautifully done. It's called Snow Babies, SNO Babies. If anybody wants to kind of look it up, I think they're going to be able to see it online. All right, so one interesting question, and we're part of a study with Nora Volkow and Jean-Jacques Wang, is, do opioid medications heal the brain? So this is actually an NIAAA funded study, because Nora is funded on it, and she's head of NIDA, so it can't be a NIDA study, right? And so they're looking to see and to give biological evidence that MAT isn't a replacement only. It gives the brain time to heal and restore dopamine functioning. So I think that's very interesting, and I think everybody's probably seen the recovery of the brain. There's a normal brain. This is methamphetamine, but there's what the scan of the brain looks like a month after detox, and you see these decreased red areas, and then 24 months later, it looks almost normal again. So we do think that these medications actually help heal the brain. All right, so let's talk about how to approach people that are having, trouble, they're abstinence-based only. My question really is, why, with all this evidence, are so many providers unwilling to offer the various forms of medication-assisted treatment with their patients? I mean, this is a no-brainer. This is, I'm going to compare it to other medical disorders in a minute, but if you look at all of the treatment providers in the country, including 10% of the treatment providers in the country are opioid treatment programs, okay? So 10% by definition are okay with MAT. They exist for MAT. And this is from the NSATS survey. So 14,600 and some treatment programs. 10% of them are opioid treatment. 12% of all treatment programs offer methadone. That includes that 10% of opioid treatment programs. So that's interesting. And then only 33% offer buprenorphine. So only 23% of facilities that are not specifically opioid treatment programs offer buprenorphine. Only 28% offer Vivitrol. And by the way, that's just the percent who say they offer it when they fill out the NSATS form. Do you offer that? I think we did that once. I know that's going on, because 98% of treatment programs also say we offer treatment in Spanish. 98%? Really? Because another 7% say we offer treatment in Farsi. Farsi? I can't imagine 7% of treatment programs offer treatment in Farsi. So my point here is, that's just the percent who say they do it. There's no, it's filling out a form. There's no, back data to support it. All right. So ASAM wrote an article, Challenging Issues in Addiction Medicine, Abstinence-Based, quote, treatment centers. And here's some of the things people said in that article. We offer Vivitrol as maintenance therapy, but we take a negative view of buprenorphine. It's substituting one addiction for another. We mentioned there's medications available, but we remind them they came here to get off drugs. It's unconscionable, frankly. Okay, what do programs really mean when they say we offer medication-assisted treatment? And this is not from a study. Here's what they mean. We use buprenorphine, but only in detox. Or we would link patients up to get Vivitrol, but not until they complete 30 days residential, and by then they don't want it. That is something I've heard. we're drug-free, we're abstinence-based. This makes me wonder something. Why aren't there 1,000 plus drug-free or abstinence-based diabetes, depression, and asthma programs? Doesn't that seem odd that we have, thousands of drug-free and abstinence-based programs to treat the medical disorder of the medical substance use disorder, and people would be aghast if somebody, had an abstinence-based diabetes, depression, or asthma program, right? So let me go a little bit more into what that sounds like to me, okay? Medication assisted. Why the outrage also over the possibility that medication for opioid use disorder without counseling is better than no treatment at all? Yes, much better with counseling, but it's better than nothing. There's no doubt about that. So that makes me wonder, why aren't insulin for diabetes, inhalers for asthma, antidepressants for medication, why aren't they called medication-assisted treatment? Why wouldn't you call a diabetes program that offers insulin medication-assisted treatment? People with all of these chronic medical disorders have to change behavior, have to take responsibility for some things that they need to do differently. Why don't we call them medication-assisted treatments? And I'll tell you why. Because they are medical disorders that people agree. People don't necessarily agree that substance use disorders or addiction is a medical disorder. So arguments against medications, we don't use antabuse, it's a crutch. I got to tell you, and I'll use my own example. I don't exercise. I can't get to it. I don't have time. I know I might feel better. I know I'd be healthier, blah, blah, blah. Somebody says to me, Denny, I have this medication you could take. And if you don't exercise when you're on this medication, you will get violently ill. I'd be like, oh yeah, no thanks, right? Because I'm not dedicated and motivated to start exercising. It hurts, So you tell me, somebody who's willing to say, I've tried to quit a bunch of times. I keep drinking. I'm willing to take a medication that's going to make me violently ill if I drink. They're the most motivated people in the world to me. And then there's the other obvious side of it. If I break my leg, aren't you going to give me crutches until it heals, until I'm able to walk without them? What is this about? Here's another one. You'll become addicted to them. You have to work the program. No chemical aids. They get in the way of the 12 steps. I've been sober for 10 years and I didn't need medications. That is like a doctor who had cancer saying, I had cancer and I didn't need radiation or chemo. I just needed, to exercise and change my diet and become spiritual. The country would be stunned if a doctor said that. So why don't programs offer or even discuss the medication options? I'm going to tell you there's financial reasons to restrict a clinical service that they don't offer. There's lack of knowledge about it. There's lack of medical staff. A lot of treatment programs do not have medical staff. There's the old timers, the way I got sober. There's moralistic viewpoints. What would that look like in the treatment for other disorders? What if you had diabetes? And for whatever reason, your medical provider felt like, needles and injection medications, oh, no, they should never be used at home for any disease. It's just wrong. You should never inject yourself. So they prescribe diet and exercise. Maybe they prescribe metformin, a medication that might not be as effective. What if a doctor held this belief that injecting medications at home was wrong, so he prescribed all this stuff, and he didn't even tell you about insulin? We do that all the time. What if you had cancer and the medical provider you saw was only trained in chemo but couldn't offer surgery? So he prescribed chemo despite there being an evidence-based surgical option, and he never told you about the surgical option because he didn't want to lose you as a patient. The country would be outraged. So cancer treatment, no discussion of surgery because I want to keep you as a patient. Diabetes, I don't offer insulin. I'm theoretically against it. We do this all the time in substance use disorders. The country would be outraged. So I would say, where's our outrage? Where is our outright outrage about that? And I think that in some way, if we can have discussions, maybe not quite that forcibly, but have discussions with people who don't believe in these things and say, don't you see how that's a lot like somebody, you know, you have diabetes, you have hypertension, you have hypertension, okay. What if your doctor said, I think everybody should control their hypertension with diet and exercise? So he didn't give you a medication and he didn't tell you about them. Isn't that the same thing? In all areas of healthcare, patients deserve to know all of the options to make a well-informed choice. So what do we need to do to bring substance use disorder treatment, including the use of valuable medications, up to the standard of other medical practices? And a lot of this is starting to happen, and it's happening slowly, but faster than it was happening 5 and 10 years ago. All right, let's talk a little bit about, and I think I'm going to run out of time. I'm not sure where I'm at here. I think they're going to tell me when I have 5 minutes left here, but I just wanted you to have this data. So I'm part of a group that's studying how COVID is impacting treatment programs, treatment delivery, and patients. And so if I get through all this, I'm going to talk about how COVID has impacted people in general, how it's impacted treatment providers and patients. I think this is the wrong order, but that's okay. So COVID has absolutely impacted opioid, alcohol, and other substance use disorder problems, overdoses, but it's also impacted child and domestic abuse, eating disorders, depression, suicide, and DUIs. The way I explain it to my friends is that if somebody has a little quirk, or somebody has a little, you know, they get angry quickly, or they're a little paranoid, or they're a little oversensitive, COVID brings that out exponentially, you know, and I think, and that is what we're happening here. COVID has become, you know, acute stress is sometimes a little easier to deal with for people than this chronic stress of COVID. So alcohol use changes secondary to COVID. Early on, how are Americans coping with COVID? They're coping with booze. There's no doubt about it. Alcohol sales rose 55% in March. In March, the stay-at-home orders didn't even happen till the second week of March, right? Tequila, gin, premixed cocktails, they are leading the pack in this, and alcohol sales online were up 243%. That doesn't surprise me because a lot of the stores closed, right? Okay. New Jersey, Ohio, overdose deaths increased 20% since COVID. Montgomery County, they're up. Ohio saw 20 overdoses in 3 weeks after COVID, in a county that normally gets 8 in 1 month. Addiction Policy Forum did a survey. 20% said they, a friend or family member, increased substance use since COVID began. 4% reported an overdose. Child and domestic abuse calls are up 22% from people under 18. Most of them identified the perpetrator as a family member, and most of them said they're currently living with that person. New York Times reported a worldwide increase in domestic violence, calls to hotlines in April. Same thing in Spain, 30% in France. Eating disorders. Hotline calls to the National Eating Disorder Association are up 70 to 80% in recent months. That was reported September 9th. 70 to 80%. Now, by the way, I actually think this would include people who didn't previously really have an eating problem, but gained that COVID-15 or what they're calling it the COVID-30 because it's gone on for so long, that get wrapped up in their dieting as kind of the one thing in life right now that they can control, you know. So the reason I say this is because it's important to catch them early. Okay. Depression and anxiety, you know, anxiety up 31%. You know, depression, considering suicide, all up. And then interesting to me, the first time I was interviewed for the transportation section of a newspaper was when they called me and asked me to talk about the fact that in Pennsylvania, the last week in February, the last week of June, they have almost as many DUI stops in June as they did in February before COVID, despite the fact that traffic is way down. And that's interesting to me. I think that people who didn't used to have a problem drinking are drinking more and more, and sometimes driving. So, all right, treatment delivery. Let me talk a little bit about telehealth. Incredible strides in telehealth lately. And what people need to understand a little bit more is that on March 13th, the President declared emergency, national emergency. That activated the Stafford Disaster Relief Emergency Assistance Act. That is what enabled us to get the 1135 waivers and the coronavirus supplemental appropriations. That is what allowed us to deliver telehealth in a new way. Prior to March, it was predominantly rural areas provided telehealth. Patient was not able to receive those services from their home. They actually had to drive to their provider, have a telehealth service with another provider that they couldn't get to. Now, and by the way, it had to be a physician. Now, doctors, nurse practitioners, clinical psychologists, social workers are all allowed to offer telehealth services because of that waiver, okay? The reason that's important is because we want these to stay after that waiver, after the Disaster Relief Act doesn't, because many people have benefited from this. And I know one of the big issues with this is that people are able to start, or one of the big wins that some people really focus on to me is that people are able to start buprenorphine without being seen by a doctor. I can't really opine about, you know, the benefits and the detriments to that so much. What I can say is that this wasn't all. Let's think about it. Let's think about after COVID's gone. What other benefits could there be? Because it's like, but wait, there's more benefits, right? What about a patient in a residential, what about patients in a residential program? It's a 30-bed residential program. They can't possibly afford a psychiatrist. Now they can get psychiatric services. In the past, if they could, they might buy 4 hours a week of a psychiatrist, and the psychiatrist might come in from 9 to 1 on Tuesday. Now, if they can get the services of a psychiatrist, it can be Tuesday night, Wednesday morning, Friday as an emergency for half an hour by telehealth. That's incredibly important because something like 60% of people coming into substance use disorder treatment have a co-occurring disorder. What about patients who can't come in person? They can get treatment. What about people who are afraid of stigma? They can start treatment virtually. What about a patient who goes to group every week and they've relapsed, they're afraid to come back? They'll never come back. What if they could just do one group virtually, find out that they're going to be welcomed back and everything, and start back up? You might have lost that patient forever. And how about the patient that could attend in person once a week, but okay, they can do it online 2 more times a week, that getting into treatment that many times. Okay, so there's all these benefits that we really don't want to have go away. All right, tons of benefits. Are we doing it? Let's look at the implementation. I'm not sure, but I think I'm getting very close to ending here. I don't know if you're gonna tell me or whether you're gonna
you still got about 8 minutes.
Sorry, thanks. I'll just go through these very quickly. The point is that you have them. These are two different studies. You know, how have you changed? You know, 72, 89% of people programs said they changed how much they use telehealth. And these surveys, one was in April, May, and one was May, June, okay? What was the most challenging thing? Technical problems, okay? What services, what percent of your services do you think you'll deliver via telehealth after COVID? If you don't think that 42% is huge compared to what they were doing before COVID, that's, you know, that is a big jump. We asked places, and this was the April, May, 338 respondents. What impact did you see on expected admissions? As you may expect, big decreases in admissions. What happened with your revenues? Almost everybody, 57% said it was down. Only 7% said it was down so much they might have to close. Can you sustain through COVID? Most are very confident they can sustain through COVID. What's the overall recovery mental health of people you serve? Most people said it's declining. And again, this is just 2 separate studies done in April, May, and May, June. If it's declining, why do you think? Anxiety, isolation, things we talked about earlier. And actually, that is it. I thought I had more there, but that is it, and I am open to questions.
Thank you so much, Dr. Carice. That was wonderful. It was really helpful to hear that information at the end too. I know the data is still new and coming out, but very helpful. So thank you for that.
Yeah.
We do have time for a few quick questions here. So the first question is, some barriers to MAT can be the numerous intersectional issues patients encounter, like housing instability. How do we promote intersectionality among these services to end harmful cycles?
Yeah, and that's a great question. It's a huge question too. And, you know, Wesley Clark, who used to be the head of CSAT, he used to say, like, you know, They don't expect you to provide housing and work training or whatever if you have diabetes or other things. Why are we expected to do that? I think it's the exact opposite. If you're so debilitated by any disorder, it's not going to get better if you don't take care of the other, you know, social aspects that have either come along with it or were there before the disorder. So, I mean, I think that there has to be an increase in treatment programs that are committed to providing a full continuum of care, including housing, including training for work and whatnot, because we know people are not going to get well without that. The past 15 years or so, there's been an increase in recovery-oriented systems of care that includes some of those things. In providing wraparound services, so it's getting better, but it's a big question without a quick answer.
Thank you. Okay, so we have another one here that says, what is the #1 thing you would say to providers in response to, that isn't my area, it's the addiction medicine doctors that should treat these people?
And am I, well, you may not know, but am I saying this, is it like in the emergency room, or is it, you know?
I think so. I think so.
Okay, so what I would say is that, you know, let us help you. Your emergency room, your office, it's full of people that are there because of drug and alcohol problems. I mean, anybody who works full-time in an emergency room knows that, you know? And yes, that's not your specialty, but a lot of places, for example, have brought counselors in or even peer support specialists that are a very, you know, very modest cost to be able to talk to people about their drinking and their using of drugs and how that interplays with their, you know, the number of accidents they have, or how that interplays with their diabetes intensely. So I think that people can say that's not their job, but you know what? It's going to benefit them to provide that as well. Now, if it's a treatment program that is more grassroots and they say that, then what I would say is that, you know, all the science shows that if you don't address people's psychiatric problems and if you don't use best practices and every tool available to us today, you're not going to be able to help your patients as much as you could.
Thank you. Okay, I think we have time for just one more. So this question says, are you aware of any movement to changing the term MAT, medication-assisted treatment, local or national?
I am, and I think that, well, it's not one movement, but I do know that we're trying to get away from that. And in fact, NIDA actually did change it. They now call it, it's still MAT, but it stands for something different. It's like medication adjunctive treatment or something like that. And again, it really goes back to, why don't we call insulin, you know, medication assisted diabetes treatment? So I agree with the concept and the idea, and there's been a little bit of work on that. And I think renaming methadone clinics, which is what, I mean, I've been in the field for 36 years, you know, so I think renaming methadone clinics to opioid treatment programs is also a big start in that in that vein. Yeah.
Great.